Good afternoon, everyone. Welcome to our Ask the Doctor workshop for children and adolescents. My name is Dr. Pat Cornier, and I have the honor of serving as the president of the NAMI California Board of Directors. We're excited today to have Nisha Warikoo, founder and director of Monarch Psychiatry of California. Nisha Warikoo is the founder and director of Monarch Psychiatry, and she's an award-winning board-certified child, adolescent, and adult psychiatrist. Dr. Warikoo is known for her thorough diagnostic approach across various stages of development, as well as the ability to provide compassionate, evidence-based, and well-rounded treatment for the patients and families she sees. She has published popular scientific articles and book chapters in the area of autism, ADHD, schizophrenia, treatment adherence, depot antipsychotics, as well as tardive dyskinesia. Dr. Warikoo is a regional expert in autism, ADHD, and mood disorders, and spends much of her time consulting and training primary care and other specialties on the best practices in management in those with psychiatric comorbidities. Dr. Warikoo is an assistant professor at UCI Health and has spent years training and educating medical students, as well as psychiatry residents and fellows in training. Dr. Warikoo is a consultant psychiatrist with Newport Academy, Residential Treatment Center for Children, Adolescents, and Young Adults in Orange County, and she has been nominated by her peers for Orange County Physician of Excellence Award for 5 years in a row and was awarded this prestigious recognition in 2019. Dr. Warikoo, the floor is yours.
Thank you so much for the introduction, Dr. Cornier. I'm really honored to be part of this very wonderful platform because being one with the community is what's really important. Mental health is not about appointments being spaced out for months and nobody's available when you need them, but it should be provided where you need it, at your doorstep, every step of the way. Having said so, I really enjoy being part of this year after year, and I'm once again honored to be part of this Meet the Doctor, and happy to answer all of your questions that you may have for me in the areas of child and adolescent psychiatry.
Thank you so much. What we can do now is any of you who have questions, go ahead and enter them into the chat or enter them into the chat function, and we'll bring them forward. Dr. Warikoo, I have a question or two for you. This has been a particularly difficult time this last 18 months across all the communities that we serve in California and across the country. And I'm curious, from your perspective, what are the specific and important things that we need to have in mind as we work with our own young folks in our families, teenagers that we are in contact with? What can you say about that?
Sure enough, these times are something most of us have never seen before, and these are really, really incredibly challenging times. Over the past year, I've had the opportunity of working across settings. Outpatient private practice is just one part, but I've worked across inpatient settings, residential treatment settings, emergency room settings. And I cannot help but notice the increase in the mental health needs of the community, especially in the child and adolescent area. There has been an increase in the severity and the levels of depression, anxiety. A lot of people, kids, adolescents coming forward with severe anxiety, severe depression, increase in the number of admissions, ER visits, increase in the healthcare utilization. But this has not translated in any increase in the resources necessarily, because the work power, the people who treat, the providers, they are the same, the numbers are the same, so the wait lists are increasing. So the burden falls definitely on the family members, unfortunately, first, and also the frontline health workers, which includes the pediatricians and the family physicians, to see and recognize that there is a need, that there is something going on. Is this anxiety? Is this depression? Is this something that they can treat or recognize? And then definitely make a referral to the right professional. Could start with therapy and then go on to a psychiatric evaluation. For family members, it is especially really important given the increased levels of isolation, given the transition from regular school to homeschool and now back to regular school. This back and forth is really hard on those with anxiety, social anxiety, neurodevelopmental disabilities, autism, and hence we are seeing an increase in the rates of major psychiatric conditions like anxiety and depression and rates of inpatient hospitalizations. So I think the most important part would be for the caregivers to have an open mind. Stigma, we are as a society moving away and or hoping to move away, but we have long ways to go. I cannot tell you how many people, how many families have come forward at 50 and 60 wondering if they had autism all their life, wondering if they had ADHD all their life. So in some ways, this past year has also been enlightening, where people have had chance to introspect and focus on something is off, something is not right. Let me just help myself understand my brain better. So just recognizing that just like any other medical condition, mental condition is no different. We rarely have control. Just like we can't control our blood pressure, we cannot control our blood sugar, we can engage in exercise, healthy diet, but it does not mean that we do not need medication or whatever other treatment approaches are prevalent. The same goes for mental health. Beyond the mild form of illnesses, medication management and therapy are very important parts of management. So just awareness of the fact that anybody can suffer from it. It could be you, it could be a friend, a family member, your own child, which is really hard to see. But knowing that a lot of these conditions are treatable and it will improve their quality of life, it will allow them to benefit from treatment, reach their full potential, is important. Once you have an open mind, often check-ins with your teenager, with your child, how is everything going? What do you need from me? But then if they respect their space or asking for some space and they don't want to talk, that could be part of normal teenage behavior, but you know your child the best. If you see a change or a deviation from how they have been normally behaving, if they're more withdrawn, if you see changes in sleep, appetite, if you see some odd behavior, sudden disappearances, there can be so much going on. Definitely stay in touch with what's going on social media, because oftentimes through text messages and social media messages, that can be a window through what your teenager is experiencing. The younger kids tend to really express themselves more through play. So engaging in play will give them a platform to openly express the themes of fear, anxiety, or sadness. And then going to the frontline health workers, if an appointment with a psychiatrist or a mental health professional is not available right away, and they would evaluate more and see if there's a need for referral. And some of them may even be willing to start a treatment plan for them.
Thank you. That's very helpful. It brings to mind some of the potential real benefit of reduction in stigma, because as family members and trusted adults and others notice changes in behavior, they'll actually more freely and more willingly entertain the idea that maybe mental health support is important. And that's a great thing to see. You know, there's a couple of questions here, one from Fabiola Nieto and one Ron Cha, that focus on questions arising from adolescent mental health and well-being in the context of the strain and stress on school right now. And what schools are doing in the midst of all of this to ensure that they're supporting the mental health and well-being of their students, and also of the teachers themselves. Do you have any comments on that?
I have to say, I really cannot emphasize on the importance of the school systems and the role they play in ensuring a well-rounded development for a child and adolescent. They spend a lot of time in their schools, around the peers, around the teachers, around the school systems. So having a robust school mental health system is critical, a critical resource, I would say, especially the public schools, where, through the individualized education plans and 504 plans, a lot of accommodations can be provided with those that are struggling in various areas. I would say I have had a lot of contact with schools for different reasons. Some can be in the form of trying to help them understand what the child needs to flourish, because we are trying to move away from the concept of one brain, one box. All brains go in one box. That's not how we are looking at it anymore. We're looking at more of a concept of neurodivergence, that just because the school has a certain environment to provide doesn't mean that all children will benefit from the same. They could have a different learning style. They might have some special needs. And we need to be very much in tune with that. I have to say that even though there's not much research and it's only been a year that has come out, but in my clinical experience and interface with the school systems across counties in the past 1.5 years, I have to say that I have not seen an increase in the funding that would allow them to provide more support for themselves and for the children and adolescents which are struggling more, especially given a lot of students went from in-person school to hybrid model or a completely remote model. I feel like the teachers are dealing with their own stress of wanting to do the best, but not necessarily having the right resources or the funding to make the most of it. I feel like they have done a great job with the different shifts of teaching systems I've had in the past year, but I personally wish that they had more support. Um, I personally think that in terms of school, it has been harder to find time and arrange meeting times to go over modifications of IEP, modifications of 504, because we are short-staffed, we have limited resources, a lot of people are working remote. So in some way, shape, or form, the typical resources that are available have been harder to get. So it's been incredibly challenging, but it's nobody's fault. It has been a very challenging and difficult year, and some thought should definitely go into what can be done to increase the funding for the school system so they can provide more support to the teachers who are so important in this whole thing, as well as more resources to the students who are going through a major change, have been for the last 1.5 years.
Yeah, I think that's all. Those are really important insights, and I think you're right. I have a question here from Cheyenne Debrin that's both focused on the current state and looking towards the future. Are there any things that you're seeing more commonly now in this moment amongst children and adolescents? And what are your concerns or thoughts about the things that we should expect to see in the future when it comes to the impact of this most recent year and a half or 2 years on mental health of children and adolescents?
We certainly have seen more. I wouldn't say it's too soon because the research data is not out, but it is clear that the severity of depression, severity of anxiety, the severity of impairments across ages, children, adolescents, young adults, has gone up significantly. The healthcare utilization has gone up significantly. It's harder to find beds, especially for inpatient psychiatry. The children and adolescents have a much longer wait time in the emergency rooms than a typical adult due to a bed shortage all across California for acute inpatient psychiatry, more so for children than for adolescents. And this has become even harder during this past year, given if some of them were positive for COVID, they would end up staying in the emergency room for days because then no inpatient unit would be willing to take them. So it has been incredibly challenging. I would say I have noticed that because especially teenagers have had more chance or more time to kind of introspect and try to better understand, spend more time with themselves and find out what is working well, what is not working well. I find that a lot of older adolescents are coming forward and wondering about their diagnoses. Do I have ADHD? I look through this and I think like I have ADHD. Even do I have autism? I feel like yesterday I had somebody, do I have reactive attachment disorder? That's because they are spending more time with themselves and they are researching, as opposed to when you're all over the place, juggling between homeschool, weekends, weekdays, the multiple activities, it in some way distracts from the time with yourself, and you don't understand what's really going on that well. So I feel like there has been an increase in the rates of children, more like adolescents, wanting to seek a diagnosis, a proper diagnosis, questioning the diagnoses. And that is a good thing. That is absolutely a good thing.
It's a very good thing. In fact, I love what you just said, because it gives me a kernel of hope in all of this, related to both that opportunity for introspection and curiosity about what's causing the symptoms and thoughts that an individual might be having. And also the idea that, it's commonly quoted that it takes over a decade from the first symptoms to definitive diagnosis. I wonder if you could talk a little bit about the benefits of timely diagnosis, and the potential impact that could have if we can get better at it.
Timely diagnosis is everything. It is absolute. It could change the course of anybody's life. And the reason is because if we treat and diagnose and treat early when we are working with children and adolescents, we have a greater chance of preventing a permanent impact on the brain from a circuitry standpoint, because those circuits are not ingrained. They can be shifted. There's still development going on in the brain. There is still pruning going on in the brain. So we can still, through proper treatment, enable development of healthy circuits and kind of let the unhealthy hyperwired circuits that are overactive fade away with proper treatment. What happens when you've had too many undiagnosed episodes of depression, anxiety, undiagnosed ADHD? It kind of feeds into each other. It's very rare to have a patient walk in and see that they have just anxiety or just depression or just ADHD. If you see somebody with depression, they might have more likely long-standing anxiety that ultimately resulted in a depressive episode. And the anxiety got worse during the depressive episode. So if the anxiety were diagnosed properly in the first place, then we probably would have a better chance of managing or not having as severe of a depressive episode in the first place. We probably wouldn't have had the concomitant or the comorbid substance use that a lot of adolescents engage in just to self-medicate their anxiety, their social anxiety, where they feel cool, they feel they can fit in because they have now managed their anxiety and they're able to artificially create those relationships where they don't have to be authentic, but they feel okay with it in the moment because they're in a bubble. So I feel like the anxiety, depression, substance use, they're all linked, and there's almost always underneath substance use underlying depression, anxiety, or an invalidating environment or other stressful things going on that can be controlled or cannot be controlled at some times. So recognizing early allows us to give the proper diagnosis to the patient that allows the patient to feel validated that, oh my gosh, this is happening because I'm not having bad behaviors in school, but I actually do have ADHD, and a badly treated ADHD or unrecognized ADHD does result in behavioral problems in school. I will have Fs and I will have suspensions and detentions, and I will be in the principal's office every other day, but only when it is diagnosed will I get the proper treatment, and I might go from Fs to As. And this is a true story.
Yes.
And untreated ADHD is not just ADHD. Because you're constantly in trouble for no fault of yours, now you have constant negative feedback from the world. That causes more depression, more anxiety, more risk of substance use. So very, very important to diagnose and treat early. I now have families or patients coming in their 50s wondering, do I have anxiety? Do I have ADHD? I feel like something is off because I am now getting around and finding the time during this COVID year to see that this can't be right. I've done a lot of reading, and they feel so much validated when they have the right diagnoses, because it's not about labeling, it's about understanding your brain physiology and brain chemistry and seeing what can be done to help it, so you're not constantly struggling, but also know what are your strengths, what are some areas that you need supports in, and actually work with the school systems and home systems to provide you the best environment where you will actually thrive in. So it is everything.
And these are things that are emerging at a very important time in life, when life's course is often set. And helping people at this point in time get that diagnosis early, reduce the impact that untreated mental illness can have really gives folks a much greater chance of following the course that they intend. You know, you open up a couple of interesting lines of thought for me, and while I ask you a couple of questions on that, I want to remind folks that you can enter your own questions as well. One is, you know, with that child or adolescent who is experiencing symptoms and has expressed concern about it, or who is displaying behaviors that it might be concerning to a trusted adult or a friend. What advice do you have for the family members, the trusted friends, the trusted adults, as to how to approach the conversation with the child or adolescent?
This is a very, very important question that you bring up because oftentimes the child or the adolescent will open up to a close friend. And the close friend, I recently actually had this exact situation. The close friend will be faced with the situation of, oh my gosh, this person told me this in confidence. And how do I break their trust? How do I tell anybody else? But at the same time, I am really, really concerned. What do I do? And in this situation that I particularly encountered, I think the first step is to really, it is the onus is on us. It is our responsibility to first of all do more community work and make this aware that it is okay to have these feelings sometimes. It is okay to have some dark thoughts sometimes or really bad anxiety. And it is not your fault. And help is absolutely available. It's kind of like if somebody has a kidney failure, they would go for a dialysis. If somebody got in a hypertensive crisis, they would get treatment for it. Similarly, when the depression and anxiety, which are the most common conditions we see, they peak or they become really severe, then it is a crisis that needs immediate intervention. Just because we don't see markers, physical or lab markers for it, does not mean it is not medical. It is medical in every sense of the way, and there are repercussions. There is risk of, you know, danger to self, danger to others, the ability to not be able to function, and everything comes crashing down. So do not feel guilty if you need to connect that person who is in a well or in a hole in the moment dealing with a crisis. Do not feel guilty. You're getting help for them. And even though they might be mad at you in the moment, in the long term, they will come back and thank you for it. They will absolutely thank you for connecting them. And they trusted you in the first place for telling you something important. And now the onus is on you to connect them to the right resource. So if they talk to a child or an adolescent, then sometimes if it is a crisis situation that I don't think I can keep myself safe, I think I'm going to kill myself, then there is no time to go through parents or anything else. At that time, whichever adult is around you, if this happens in a school setting, you call 911. You call 911, or you tell the teacher, ask them to call 911. Take them to the nearest emergency room where they will be evaluated by a psychiatric team, and there's no other way to get that urgent evaluation done. Now, if it's something like I'm going through very dark times, I don't feel like myself, and there is no imminent safety concern, that is something that can be brought to the attention of the parent. That, this is what she said, why don't you touch base with them? And I'm sure they will appreciate, because oftentimes what the teenagers experience and what the parents experience are completely different things. What the parents observe are completely different from the teenagers. And it's not because they don't have a good relationship, it's just the nature of the dynamic. So that is the best way to go.
You know, it strikes me as an extension of the idea that we're trained to be patient-centered, and in that case, you're talking about being person or friend or centered. In other words, what are their needs right now? Don't worry about what their friends might think or what their parents might think in the moment. You got to be focused on what their needs are right now and responding to those. That's really helpful. And that gets me to another thing. I'm a family physician and have had the great pleasure of working in an environment where we had set up a collaborative care model that included embedding mental health professionals and support right in a primary care clinic. And the fact that you are involved in training family medicine and primary care students and psychiatry residents and fellows. I'm curious your thoughts on what it is you say and teach and try to bring forward that those students carry through to the rest of their careers.
So we are, I think the first thing is recognizing that is the only, we can never overcome the shortage of psychiatrists and child psychiatrists, and knowing how many are going to retire in the next 5 years, we don't even want to talk about that because we're only going in more and more shortage, and the mental health needs are increasing day by day. So the only way to actually provide access to care for early diagnosis, early treatment is to train the frontline health workers and people and folks who come in regular contact outside of family, like the school systems. So if we empower the frontline health workers and the school system in ways of providing them a lot of education about what are the red flags, what do you do, when is a good time to refer, so that their anxiety about what is this, what do I do about that is reduced, and provide ongoing support. I think that is the need of the hour. That is the only way, because a lot of the psychopharmacology, medication management can be done by frontline health workers, provided they're given the proper training and have the proper hand-holding and supervision in the beginning. So Dr. McCarran, who's also on the board of directors, and I think he's giving a talk simultaneously. He's been my supervisor and colleague in UCI. Is doing the TNT Train New Trainers program for physicians, which it is a fellowship program and it has expanded to so many physicians across California and possibly to other states now too. And this is now for adult psychiatry, not for child yet. Basically a fellowship program where you engage the physicians. The funding comes from the state, so the physicians are not burdened by it. And they have a curriculum that they go through for basics of mental health, basics of psychiatry 101, depression, anxiety, ADHD, autism, the most common conditions, the most prevalent conditions, and clear ways of how they are treated in terms of mild and moderate conditions, and what is a good time to refer. And this is associated with mentoring sessions 1 to 2 times a month, which are individualized on Zoom, and conferences twice a year. And at the end, these primary care providers who complete this certificate program are given like a certificate of completion of TNT, that they are now a certified provider where they have the support. And this is not just your fellowship got over, now you have no contact, you're actually building a network and you can reach out anytime. And that is what is needed. And I have been in conversations with Dr. McCarran, it's a blessing that this program exists for adult psychiatry, but we need this program for child psychiatry. So we have been in conversations about that, and there may be a possibility that such a program might happen, and I don't want to say anything until it finalizes soon. And
it's hardly a secret,
right? And when it does, we need that. That's exactly what we need, because we cannot recreate or produce the workforce, and it's not, I can sit in my office and see one patient in half an hour, 1 hour, but it doesn't help the 10,000 other patients who are being unseen.
You know, and that's a place where the audience for this can have an impact, in that it does make a difference if, when seeking a primary care relationship, you ask, do you practice in a collaborative practice environment that embeds mental health, and ask whether or not that's a part of what is offered. Reinforcing the idea that that's something that the community wants is a big help, I think. And so as family members who are part of NAMI, and as those affected by mental illness ask those questions, it'll help support and reinforce that. You talked a little bit about medication management, and I know that one of the anxieties that many have is what is the role of different ways of supporting a patient or someone with a mental health condition through therapy and training and medication, and any thoughts you have on that?
Absolutely. Um, it's great that you bring that up, because even though the stigma is reducing, we still have a long way to go. There's plenty of families who wait for decades and even getting diagnosed, and even after getting the diagnosis, getting started on the right medication. In the process, they might seek help from marijuana that is readily available, to self-medicate for anxiety and sleep disorders in the moment, not knowing or not being fully aware that it only makes anxiety worse or depression worse in the long term, and even is responsible for causing a significant drop in your IQ points.
Mhm.
So because it's readily available and it's legal, so why not? And it helps in the moment. So the when people go online and search for a medication, any medication comes with a million side effects. Even if you type candy, it'll come with a million side effects. But if you are treating the condition properly, first of all, accurate diagnosis, and then slow, steady steps towards starting a slow dose of medication, low dose of medication, one step at a time, not making too many changes at once or quick changes, knowing that these medications take at least 6 to 8 weeks to achieve the full effect. So giving it that time rather than keeping on increasing until you've given it the full time, making sure there are no side effects along the way. So the major classes of medications are definitely, good thing is that for depression and anxiety, the antidepressants work for both depression and anxiety. So anytime the depression and anxiety reach a moderate to a severe level, which means they're getting in the way, it's really significant decline in functioning, having a lot of anxiety attacks, having some passive thoughts of not wanting to live, poor sleep, poor appetite, that's when you know you need to change the brain chemistry that has been altered by the depression, the anxiety, which is the serotonin imbalance. And the medication in conjunction with therapy will help correct that imbalance, but it is kind of like a prolonged course of antibiotics. So it's not like a 10-day course of antibiotics, it's more like a 10-month course of antibiotics. So you have to continue that until that time, and then you should work with whoever your treatment provider is to kind of taper it off. The antidepressants are very safe, well tolerated. Like I said, work with both depression, anxiety conditions, rarely cause any long-term damage in any organ systems, does not cause weight gain, or do not make you feel like a zombie or personality changes. On the contrary, they can make a huge difference in your outlook in life, in your ability to function, to really feel like you can live this life at your highest potential, rather than suffer from anxiety attacks, rather than have severe debilitating anxiety, severe depression. It makes a huge difference. Sometimes it's also about recognizing that anxiety and depression may always not present the same way. As okay, depression is like feeling down, and anxiety is like really having those anxiety or panic attacks and feeling like, or having OCD. Sometimes anxiety may present as anger outbursts, and it comes out as behavioral problem, and there's aggression, and that happens a lot in those who have autism, that they don't know how to verbalize it, recognize that it comes out as anger outbursts. And SSRIs or antidepressants play a huge role. I mean, I've had patients and families who never left their child alone for like 12 years, and once their separation anxiety was treated, they went on a date night for the first time ever, and it was the best thing. Or parents who have never slept because they barely get 1 hour of sleep at a stretch because there is such horrible sleep issues in their child, which are finally treated, and now they're able to sleep through the night. So there are big wins. Or somebody with severe ADHD who's getting Fs and getting called into a principal's office is now an honors roll because it was just ADHD. It was just the neurochemistry we needed to fix with the medication. But at the same time, we cannot undermine the importance of therapy. Therapy is really important
Yep.
because ultimately it will be those coping skills and recognition of your triggers, and learning what is a better coping skill than going smoking a joint. What is a better coping skill than getting mad or punching the wall? That will help in the long-term management of these conditions. Uh, so rather than relying on, the internet blogs and Google and what they have to say, talk to people who have been, involved or have taken medications. And there's not, mostly I have to tell you, if 1,000 people come to this clinic, 999 will not write a review because they're doing so well. They're just happy. And the one person who had a bad experience is the one who's going to go online and write a review or a bad experience with the medication. So just don't go to Google. There are many other reliable sources of information for medications, and conferences like this that educate and empower families are important as part of getting more awareness.
That's that hopeful message, I think, is critically important. And in fact, not only do we carry the burden of stigma that is now lifting, and I think making people realize when they can and should seek treatment, we also carry, I think, the burden of a history of a really pessimistic feeling about the implications of a diagnosis of a mental illness. But I must say that in my practice, I really, really enjoyed taking care of patients who present with mental health conditions, because there are so many of those stories that you just shared. Can you talk a little bit about the way we think about a recovery orientation in mental health care in ways that maybe in decades in the past weren't really as prominent as they are now?
I'm sorry, can you repeat those questions?
Yeah. Can you talk a little bit about how the orientation has really shifted to a more positive recovery orientation when it comes to the treatment of mental health conditions for children, adolescents, and in general, as opposed to the way it seemed many years ago?
Absolutely. I think we have come a long way and we have a long ways to go still, but it's more like rather than treating the condition right now in the moment, in the current month, or in this one setting, where are we looking? Where are we headed a year from now, 5 years from now, 10 years from now? Uh, what do we need to do to get there? And not just medication management. Medication management is a very small part of it. And very often psychiatrists do get confused with, being pill pushers. And I have to say, everybody has different practice styles, but medication is a very small part of it. I think the big responsibility is first diagnosing correctly. Is this bipolar? Is this not? Because that's a completely different line of treatment. Is this depression alone or with anxiety? Is this ADHD or is this ODD? Is this autism or is this really bipolar disorder? And sometimes PTSD can also be very confused with a lot of these conditions. So diagnostic accuracy is very, very important in order to kind of try to formulate a treatment plan. And then medication management is just in the moment, even after completing a course for 9 months. For example, for a teenager who's going to be 18, 6 months later, we need to think about how is the transition going to look, a transition to college. What are the supports and services do they need to get in their college? Do they have access to the disability center? Could they benefit from some accommodations from the disability center? What are some of the supports and services they need within the family that is contributing to the stress level that results in substance use? For example, do they need family therapy? Does the family need more education about the medications and how the family heightened stress and emotion does contribute to relapses? So we need to look at the overall picture rather than, oh, yes, we have this depressive episode, we treated it in 9 months and we're good. No, nothing is good. In the moment, we're good, but it's going to come back if we do not address the things that contributed to it in the first place, because it might be associated with undiagnosed ADHD, which resulted in a depressive episode, or an undiagnosed autism, or an undiagnosed anxiety condition, which will have very different implication in terms of the treatment plan. So as a child psychiatrist, I have to look at medication, first correct diagnosis and medication. Are there any medical conditions like vitamin D deficiency, B12? I get those panels on every single one because it does contribute to some somatic aches and pains, thyroid abnormalities. Then looking at the systems and supports in the family, in the school, Do they need an IEP, which is individualized education plan, or any special accommodations that would help reduce the stress and provide the right environment for them to thrive?
Mm-hmm.
And then connecting them to the right resources in the community. And there are so many right resources in the community that people are not aware of. The regional center provides so much for our patients with neurodevelopmental disabilities, transition resources, newly diagnosed autism resources. For those with, somebody needs vocational rehab, connecting with the DOR, connecting with conservatorship resources, and then other aspects. So it's truly about, yes, we have to treat the acute condition, but how can we help promote recovery, which would mean not putting them in the same box as the other brains, but trying to understand this brain and seeing what are the type of environments that this brain will thrive in, and how do we help recreate those environments wherever they come in touch. So the more we do that, the better chances we have of touching more lives, as opposed to, yes, we just fix a depressive episode.
Yeah. I have a question from Rachel that touches a little bit on something we spoke to before. The fact that family members are often a part of what's going on with a patient, helping to support them, serving as their advocate and as a sounding board. And one area that can create a great deal of stress is knowing or getting comfortable with the idea of whether or not medication is needed. And sometimes having a family member who is getting treatment, who is doing well, but doesn't want to be on medications anymore. Can you give advice or say a few things about how do you know when it's needed? How do you handle a situation where a loved one is saying, I don't want to be on these medications anymore? What are your thoughts?
Right. So that is something we encounter a lot, unfortunately or fortunately, and depends on the age. Really how we handle it depends on the age. If it's somebody not a teenager, then they're at a different developmental level, and a teenager where they're trying to learn how to become more autonomous and independent and build confidence in their own decision making, we have to approach this differently. So for a 14-year-old or a 16-year-old or a 17-year-old, it has to be more of a collaborative decision making, even though they are legally, they're still minors and they still cannot provide full informed consent. But it's very important for them to be part of decision making. And I think, and I do recommend, and in my practice style, I do make them completely a part of the discussion. And one is to try to understand the ambivalence of why do they not want to be on medication if a medication is indicated. Not to say that's indicated 100% of the time. And sometimes it could be, I don't like going to the nurse's office for this noon dose of the medication. And then there are ways around this. Or I wish, I think I'm the only one getting this medication. I think something is wrong with me. And I don't want to be looked at like that. I'm not special needs. So trying to understand the reason for ambivalence. Is it really a certain perception of the medication or the meaning that is attached to the medication that we need to work with, rather than forcing the medication without understanding the ambivalence? The second reason is, if it is truly because of a side effect, then yeah, we should work with that. Do we need to lower the dose? Do we need to switch to something else? And I feel like when they're heard, they're more receptive to those changes. And if it makes sense, if the symptoms are milder and if they've been stable for over a year and doing well, then we could come up with a plan of, okay, well, we'll see. It sounds like you've been doing well for a year on these medications. So maybe at a time where you're not having finals week, or it's not a stressful time during the summertime, maybe we can take one of these meds, taper it down, and see how you do. If the symptoms come back, do you think it's reasonable to get back on the medication? Or if they don't come back because you've completed the course, it's totally fine. So there are different factors we look at. If it's typically a mild condition that doesn't get in the way so much, therapy is sufficient and supports are sufficient. But if it's a moderate to severe condition where it really gets in the way, then we do have to complete the course. But for a teenager, it has to be collaborative decision making and understanding the actual reason for not wanting to take the medication and trying to work with that.
I love that exploration and engagement, and the idea of timing being so important, and recognizing that there are times to make some changes, and there are other times where the risks are fairly high, and also the idea that you look forward. We've got a time coming up when there are finals. Doesn't mean we start on medication, but let's watch a little more closely and be prepared, or any kind of a plan that helps you to be in a position to prevent things from becoming much worse if circumstances change and stress increases, or otherwise increases the risk of a problem. That's really helpful. In that space, there's the transitions that you talked about earlier. Moving, for instance, from high school to college, moving from middle school to high school, and the implications of those transitions. And how do you advise, or what are your thoughts about supporting teens, adolescents, children through those transitions, and doing the best we can as family members, or they can as the individual affected, to make those transitions as safely as possible?
Absolutely. So definitely one part of it is working collaboratively with a health provider, right? It could be the frontline, family physicians, pediatricians, or if they're working with a child, an adolescent psychiatrist, or a therapist. If you have that relationship, then understanding the patterns of the impact of transitions, how have transitions historically been, and what seems to be the most challenging part. And the biggest problem with challenges we see in a lot of social anxiety and autism spectrum disorders, high functioning, the transition from summers to school starting is an absolute nightmare for both. Like, it's really, really challenging. And basically it's that break in routine. Some of them may thrive in a structured setting, but then this back and forth can be really hard. So absolutely, planning for transitions is key, rather than making them go through it without that actual planning and having the support system in place. So if, for example, if I have a patient who's had historically behavioral outbursts right around the time of transitioning from summer school to, or no school to, start of the next school year, and then school avoidance and missed weeks of school out of anxiety and transition, then I would work preemptively for the private 2 months and make sure if from a medication standpoint, they're at an optimal level, is it well managed, increase the frequency of therapy at least a few weeks before the transition, and have more frequent appointments during the transition to support them and help them, make them understand that this is temporary. It's kind of like a ride the wave. It goes up, it comes down. You have to ride it. If you don't ride it, it will stay up, and it'll be, the next transition will be harder, and it's going to be a higher wave and a higher wave. But making sure they have the support, and for the families to know that, yes, they do struggle during this time. Yes, we do need extra help during this time. And yes, there will be some tardies in the mornings, but we are not going to be punitive, because this is anxiety, and we have to work with anxiety. Just like we would work with somebody who has some medical problems or something that shows in the system, as opposed to anxiety that shows as, I just don't want to go to school, I have a stomachache, or I don't like school and I hate school and I'm not going to school, or just having a big tantrum, which is essentially anxiety. For some of the more ones on the spectrum who have some special services in school, IEP, 504, making sure they have the right resources there. Some of them may need like a letter saying, hey, we've seen an exacerbation of symptoms, please provide them with an aid if there's a safety concern, or access to a counselor, or somebody on the bus where they seem to have more behavioral outbursts because it's more overstimulating in the bus. So there's different factors depending on the case, but supporting them in the family, educating the family, this is going to be hard, please be patient and understand that this comes from anxiety, it's not personal, and we need to address it as is. And then optimizing medication, increasing the frequency of therapies, as well as providing or maximizing the supports and services they have in school. When it comes to transition to adulthood, I feel like a lot of I found the regional centers to be really, really beneficial. Really, they have such amazing programs for families, for those especially on the spectrum, connecting them with vocational rehab, and who adolescents or teenagers who have a hard time understanding safety things, Get Safe program as part of regional center. They have so many things that can be done as part of that help the family understand the different aspects of what needs to be done.
Yeah, that set of tools, that set of things to anticipate is, I think, really, really important, really helpful. I'm thinking to myself that part of the treatment that is needed for family and for the person affected by mental illness is knowledge. And, all of the insights that you shared have been really important. And I think also, tying this back to NAMI and NAMI's programs, because it does focus on peers, it does focus on family and how they can navigate this effectively. It's a really good blend of sources for insight and support and knowledge that can really make a big difference in the lives of individuals and families affected by mental illness. So, with that lived experience. Um, I'm going to pause for a moment and do a little bit of housekeeping, and we'll wrap up with a question or two. And I know that Jessica has a recording that we're going to play at the end for the last few seconds. So I just want to warn people that that's coming. And I want to thank you, Dr. Warikoo, for the time you've spent with us today. It's been a lovely discussion, a lovely conversation, really. Responding to questions from the audience, exploring some of the things that your background and your experience has made me curious about, and I appreciate that. As we've said before, any other questions or concerns for today's event, please feel free to email NAMI at nami.california@namicalifornia.com, NAMICA, or .org, I'm sorry. We're going to be getting that recording from Jessica in a couple of minutes. I'd like to ask, are there any last comments or thoughts that you have to share that you'd like others to be thinking about, or things that I haven't asked you that you really wanted to spend some time exploring?
There is one big message that I have for everybody today, and that is that as a child and adolescent psychiatrist, and also as a mom of two kids, life happens, things happen, even for us, for everybody, and we can't always control it. It could be a family situation, it could be some unexpected loss, it could be so many stressful things that happen. It's very important to stop and take care of yourself first before you take care of your little ones, because only when you take care of yourself would you be able to do a better job taking care of the others. I think our prime responsibility is to take care of ourselves guilt-free, and then we will be better citizens and better parents and better colleagues and better people in the community. And I would say, how many people are taking out time for self-care, like 1 hour a day? Even though there are 24 hours in a day, how many people are able to take out 1 hour a day doing what they feel is self-care for them? And it could be different things for different people. And just that might be enough. Or recognizing that you're feeling overwhelmed because of so much that's happening, and then that you need to schedule some downtime for yourself, something for yourself, so you're able to kind of decompress and feel better and rise up again to face the challenge. And that's okay. Don't have to feel bad about that, because at the end of the day, we do pass on our moods and anxieties to our kids. And if we are happy, if we are healthy, and so will our kids be. So that is something that I really have had to say at the end of it. And I'm learning that myself. I'm having kids myself has taught me so much. And I would not be a good or close to anything if I did not have children for myself. Otherwise, I would just talk out of the air. I would not have any personal experience at all. So I think that's the only thing I would like to focus in the end: self-care.
I love that, because not only is it good for you, but it's a great modeling, great example for your little ones, to see that a part of a healthy life with good well-being involves that kind of self-care. So that's deeply wise, and I appreciate you bringing that up.
Thank you.
Thanks again. This has been just delightful. I want to invite everybody who's participated today to take the evaluation survey that will be sent to you at the end of the conference. We use that feedback. We want to make this experience better and better every year, and your feedback is critically important to that. As you've just heard, please remember to take some time and breaks for your self-care. And we look forward to seeing you again. The work we do together at the local affiliate level. And again, Dr. Warikoo, thank you so much.
Thank you so much for having me.
Of course.
Thank you so much for attending the NAMI California 2021 Annual Conference. Now you have the tools in your toolbox to help you advocate every day for yourself or your family. And we'll see you next year in Newport Beach for our 2022 NAMI California Annual Conference. Thank you again.